I mean, just imagine paying like $3,000 to have microscopic holes intentionally burned right into highly sensitive, intimate tissue.
Yeah, it sounds incredibly intense.
Right. And all of this is based on the promise of a non-surgical quick fix for aging. So today, we are taking a deep dive into the absolute explosion of non-surgical vaginal rejuvenation.
It really is a massive industry right now.
It is. And it's an industry caught squarely between, glowing, miraculous clinic reviews on one side and severe flashing red FDA warnings on the other.
Exactly. And the contrast is honestly pretty jarring when you lay the sources side by side.
Yeah, we've got a huge stack of sources sitting here today. We're looking at clinical trials, international medical consensus documents from groups like International Continence Society, and of course the glossy clinic marketing materials that make these procedures look like, I don't know, a relaxing trip to the day spa.
Right, you've got these brochures promising youth and vitality sitting right next to stark medical warnings about permanent tissue damage.
Which is wild. And we know you might be insanely curious about the sudden ubiquity of these procedures because they are being heavily marketed literally everywhere right now.
No, absolutely everywhere.
They claim to treat pretty much everything from natural age-related changes to postpartum looseness, all without going under the knife. So our mission for this deep dive is to cut right through that marketing spin.
Yeah, to get to the actual science.
Exactly. We're going to look specifically at how these non-surgical vaginal tightening treatments actually work. We want to get to the physiological facts of what happens when you introduce powerful energy-based devices to the human body.
Because, even if you aren't personally seeking out these treatments, the underlying science of how the body heals, how it responds to intense thermal stress, and how it attempts to remodel its own tissue is just a fascinating biological puzzle.
Okay, let's unpack this. Because before we can dive into the mechanics of the lasers and the ultrasound machines, we kind of need to understand the biological reality they're actually trying to fix.
Right, the root of the problem.
Yeah. And that primarily brings us to two main conditions. First, there's GSM, or genitourinary syndrome of menopause, which the medical community used to just call vulvovaginal atrophy.
Yeah, the terminology shifted.
Mm-hmm.
But basically, GSM is a systemic issue fundamentally driven by a drop in estrogen.
So it's tied to menopause.
Exactly. As women enter perimenopause and menopause, that lack of circulating estrogen dramatically alters the whole pelvic environment.
How so? Like, physically, what
The
happens?
vaginal walls thin out, they lose their natural elasticity, they become incredibly dry, pale, and they're highly prone to inflammation.
Wow.
And we are talking about an incredibly common physiological change here.
Right.
Almost 50% of postmenopausal women experience these symptoms.
Wait, 50%?
Yeah, half.
That is a massive portion of the global population. Yet, our sources highlight a truly wild statistic about this. Despite how nearly universal this is, 81% of women don't even view it as a medical condition.
It's heartbreaking, really.
It is. They just suffer through the burning, the itching, the pain during sex, assuming it's just, an inevitable, unavoidable punishment of aging.
Right. And the symptoms can severely isolate people. It really degrades their quality of life. But historically, women just haven't been encouraged to complain about pelvic pain.
Right, just grin and bear it.
Exactly. Which leads to this massive silent epidemic of discomfort.
To help you visualize the physical reality of GSM, think of the vaginal tissue kind of like a kitchen sponge that's just been left out on the counter in the hot sun.
That's a really good analogy.
Right. Without estrogen, which basically acts like the water keeping that sponge soft and pliable, the tissue loses all its plumpness. It gets thin, brittle, and becomes very easily irritated or even torn by the slightest friction.
And then the second major condition driving patients to these clinics is vaginal laxity, or VL.
Which is different from GSM, right?
Very different. Unlike GSM, which is primarily about the health of the mucosal tissue itself, laxity is a physical, structural feeling of looseness.
And this is usually linked to major physical trauma, right? Like specifically stretching or tearing of the levator muscle during childbirth.
Yes, childbirth is the main one, but also just the cumulative effects of the natural aging process on our connective tissues over time.
Okay, so the levator muscle.
The levator ani is essentially the hammock of the pelvic floor. When that muscle is overstretched or physically torn during delivery, the patient can experience a significant loss of physical sensation, sexual dissatisfaction, and stress urinary incontinence.
Which is the clinical term for, like, leaking a little bit of urine when you laugh or cough or sneeze.
Exactly, because the structural support around the urethra has been compromised.
So you have millions of women dealing with either a dry, brittle sponge or a torn, muscular hammock.
If we connect this to the bigger picture, you really have to look at the historical landscape of treatment options for these incredibly bothersome conditions
Right.
because they were notoriously limited.
Oh, totally. You basically had Kegel exercises, which, let's be honest, require intense daily dedication for months to see any real results.
And even then, they don't fix everything. You also had systemic or local hormone therapies.
Which care there are complex risks, right? And some women simply cannot take hormones at all.
Right, like certain cancer survivors.
Mm.
Or, for severe laxity, your only other option was going under the knife for invasive surgery? A vaginoplasty.
Which sounds intense.
A vaginoplasty is a major surgical intervention. You're looking at anesthesia, scalpels, incisions, and up to a 6-week, highly restricted recovery time.
So it's no wonder there is a massive pent-up market demand for a non-surgical alternative. Women desperately wanted a solution that didn't require daily physical therapy or messy hormones or a scalpel.
We wanted a quick fix.
Yeah, and it's genuinely wild to think that the solution the industry came up with simply involved, like, rolling machines down the hallway from the dermatology clinic straight into the gynecology clinic.
Literally. These were devices being used to zap wrinkles and acne scars.
That aesthetic migration is exactly what happened. The cosmetic industry saw a totally untapped market and just repurposed their technology. Which brings us to the core question of this deep dive. How do these energy-based devices actually execute this so-called rejuvenation?
Right. Let's look under the hood of the technology.
The industry relies on three main types of energy. The first, and honestly the most widely researched in our stack of sources, are the lasers.
Specifically, fractional CO2 and erbium.YAG lasers.
Yeah. The claim here is that these devices fire microscopic beams of light to create columns of controlled thermal injury in the superficial epithelium and the stroma. Let's pause there because we definitely need to define those layers for you listening.
Sure. So the epithelium is the topmost layer. It's the surface lining of the vaginal canal.
Okay, surface.
Right. And the stroma is the layer immediately beneath it. It's essentially the structural scaffolding made of connective tissue, blood vessels, and nerve endings.
So the laser is literally burning tiny microscopic holes right through the surface lining and down into that structural scaffolding.
That is the precise mechanism of action, yes. The light energy converts to intense heat, vaporizing the water in the cells and intentionally causing microscopic destruction.
Wow. But burning microscopic holes with light isn't the only way to generate that heat, is it?
No, it's not. The second technology they use is radio frequency, or RF.
And instead of a laser beam, RF uses an electrical current, right? Usually around 460 kilohertz.
Exactly. RF relies on the tissue's natural resistance to the electrical current to generate the heat.
Kind of like an old incandescent light bulb.
That's a perfect way to put it. The filament glows and gets hot because it's actively resisting the electricity flowing through it. So the RF device targets the subdermal collagen layer, heating it up without necessarily vaporizing the surface the way a laser does.
Which brings us to the third method. If lasers and radio frequencies still have to pass through the surface to reach the deep tissue, is there a way to bypass that top layer entirely? Like, so you aren't burning or heating the mucosal lining at all?
Yes, that's where ultrasound comes in, specifically high-intensity focused ultrasound, or HIFU.
Oh.
Right. HIFU relies entirely on acoustic energy. It uses highly focused sound waves that penetrate much deeper into the body.
Huh.
We're talking 1.5 millimeters, 3 millimeters, and even up to 4.5 millimeters deep.
So it skips the surface.
Completely. It works very much like a magnifying glass, focusing sunlight on a leaf. The sound waves pass harmlessly through the mucosal layer, but they converge at a very specific, deep focal point. At that point, the intense vibrations create focal zones of thermal injury deep in the muscle and connective tissue layers.
Okay, just to round out the picture, our sources do briefly mention injectable alternatives trying to achieve similar rejuvenation. Things like the O-shot.
Right, which involves spinning down your own blood to extract growth factors and injecting them back in.
Yeah, or even injecting collagen directly to augment the G-spot. But those are chemical or biological interventions. The energy devices, the heat and the burning, those are the heavy hitters absolutely dominating the market right now.
Definitely. And to truly grasp the physiological goal of these energy devices, we need to look at how the body responds to trauma.
The great way to visualize this is to think about aerating a compacted lawn, or maybe like a controlled forest fire.
Exactly. You are intentionally inflicting damage to the tissue.
Right. The heat from the laser, the RF, or the ultrasound basically tricks the body into thinking it has sustained a major wound. This forces the body's natural wound healing response into absolute overdrive, clearing out the old, weak collagen and prompting a rush of fresh, lush, new growth.
Biologically, it's a very specific cascade of events. The immediate thermal effect causes initial edema,
Which is swelling.
right, swelling in the tissue.
Yeah.
And this swelling is the first phase of wound healing. The intense heat activates localized cells called fibroblasts.
Fibroblasts.
Yeah. Fibroblasts are essentially the construction workers of your body's connective tissue.
And when they wake up, they get to work fast.
They really do. When activated by the thermal injury, fibroblasts kickstart a process called neocollagenesis, which is just a fancy word for the production of brand new, tightly woven collagen fibers. Simultaneously, the body initiates neovascularization, building new micro blood vessels to supply this wounded area.
So the clinical promise being sold to the patient is that once the body finishes this emergency construction project, you are left with thicker, more elastic tissue that has a better blood supply, which theoretically translates to better natural lubrication and a tighter physical structure.
That is the exact narrative presented in the clinic brochures. A quick, painless zap, your body naturally heals itself and you walk out rejuvenated.
Which, I mean, the law narration analogy sounds amazing on paper, but here's where it gets really interesting. When you actually take a biopsy of that treated tissue and look at it under a microscope, this story gets incredibly complicated and, honestly, highly debated.
Oh, this microscopic analysis is the absolute epicenter of the medical controversy right now.
Yeah.
Some of the clinical trials provided in our sources show biopsies taken 1 to 2 months after a laser treatment. And those specific slides do show a thickened epithelium. They show an increase in glycogen.
Which is a sugar that feeds the healthy bacteria in the vaginal microbiome, right?
Exactly. And they show elongated capillaries.
See, that sounds like a win.
It does. But international societies, like the International Continence Society and the International Society for the Study of Vulvovaginal Disease, are crying foul on how we interpret that data.
They point out a pretty critical blind spot.
They really do. They note that if you take a biopsy just 1 hour after a CO2 laser treatment, the tissue looks absolutely devastated.
Wow.
You see superficial desquamation, meaning the top layer of tissue is literally slumping and peeling off, and you see severe tissue coagulation. Basically, the tissue is cooked.
Cooked. That's horrifying. Pathologists looking at these post-treatment biopsies are seeing histological changes like acanthosis and parakeratosis.
We definitely need to define those.
Yeah, if I'm looking through the microscope, what exactly is acanthosis?
Acanthosis is an abnormal thickening of the skin layers. It's essentially the tissue building a tough, chaotic callus to protect itself from the burn.
Like a callus on your foot.
Right. And parakeratosis happens when the body is rushing the cell-building process
Right.
so frantically that the new cells don't even have time to shed their nuclei correctly before reaching the surface.
Oh, wow.
Yeah, it is a clear sign of distressed, rushed healing.
Okay, I have to push back on the entire premise of calling this rejuvenation then.
Yeah.
Because if I accidentally burn my hand on a hot stove, my body will heal it. And the resulting scar tissue on my hand will definitely be thicker, and it will definitely be denser than the healthy skin around it.
True.
But I would never look at a burn scar and say my hand has been rejuvenated or is functionally better. So how do we know these incredibly expensive machines aren't just creating a dense matrix of internal scar tissue that just feels tight, masquerading as youthful tissue?
What's fascinating here is that your burn scar analogy is the exact argument being made by skeptical gynecologists and pathologists.
Really?
Yes. Those cellular changes,
Yeah.
the callus, the rushed cell turnover, they are entirely consistent with the standard repair of a severe thermal injury. It is highly contested whether this matrix of new collagen truly represents a return to premenopausal, functional, healthy tissue. The alternative, which many fear, is that it's simply a temporary inflammatory swelling and scarring response.
So you burn the tissue, it swells up and scars, and for a short window of time, the patient perceives that swelling as tightness.
Exactly.
That is a genuinely terrifying thought. You might be paying thousands of dollars just to permanently scar your most sensitive anatomy. And because of this microscopic uncertainty, major medical authorities have stepped in to basically violently hit the brakes on this entire industry.
They felt they had absolutely no choice. In July 2018, the U.S. FDA issued a very severe public warning against the use of energy-based devices for vaginal rejuvenation.
They stated point blank that the safety and effectiveness of these devices for treating menopause symptoms or laxity are simply not established.
And the FDA isn't standing alone on this.
No, not at all. Groups like the American College of Obstetricians and Gynecologists, the UK's NICE guidance, and the International Continence Society have all echoed the alarm here.
They emphasize a really crucial legal distinction that gets lost in the marketing. These lasers are FDA cleared for general cutting and coagulation of tissue.
Like burning off a genital wart or excising a precancerous lesion.
Precisely. They were never specifically approved or tested for treating GSM, atrophy, or vaginal laxity. It's considered off-label use.
And the glaring issue is the evidence gap. When you dig into the studies that the cosmetic clinics use to support these devices, the scientific flaws are just staggering.
They really are. Most of the studies involve very, very small groups of women.
Yeah, and they almost entirely lack control groups or sham treatments, meaning they didn't compare the laser to a fake laser treatment to rule out other factors.
Which is standard in rigorous clinical trials. Plus, the follow-up times are usually just 12 weeks, maybe 6 months. We have absolutely no idea what happens to this artificially scarred tissue 3, 5, or 10 years down the line.
And crucially, many of the studies showing positive results are directly funded by the manufacturers of the machines themselves.
Which introduces massive bias.
Absolutely. But let me ask you this, because we have to look at the other side of the coin presented in our sources. Despite the FDA warnings and the lack of long-term data, clinics are reporting that 84 to 86% of their patients are highly satisfied after these treatments.
The satisfaction numbers are undeniably high.
Right. So if the evidence is so weak, why are the satisfaction rates so incredibly high? Are thousands of women just experiencing a massive placebo effect?
Well, the power of the placebo effect in this specific area of medicine cannot be understated. One of our sources explicitly notes a stunning meta-analysis. Up to 67.7% of the treatment effect for female sexual dysfunction can be accounted for by the placebo effect alone.
Wow, 67.7%, nearly 68% of the improvement is purely psychological. You have to explain the WHY behind that. How does the brain trick the body into thinking a laser worked?
Female sexual arousal and pelvic comfort are incredibly complex mechanisms. They're heavily influenced by the nervous system. Arousal requires neurological signaling, blood flow, and psychological relaxation. If a patient believes they have just received a cutting-edge, highly effective treatment, their baseline anxiety about pain during sex plummets.
Oh, that makes sense.
Yeah, and that drop in anxiety literally changes the physical signaling in the body, allowing for better natural lubrication and relaxation of the pelvic muscles.
It's the brain telling the body it's finally safe to function normally again. Plus, you have to factor in the sheer weight of confirmation bias.
Oh, definitely.
These treatments are considered cosmetic, so they are not covered by insurance. They are entirely out of pocket. If you just handed over $3,000 for a laser treatment, your brain desperately almost needs to believe it worked. Like, I paid for it, it hurt a little, so it must be tighter.
That cognitive dissonance is very real. However, we do have to be fair to the data we have.
Right.
For certain specific severe symptoms, there does seem to be a real, measurable, physiological benefit that goes way beyond placebo. Take dyspareunia, which is the medical term for severe pain during sex. Large observational cohorts show that for dyspareunia, the benefits of a fractional CO2 laser can actually be durable for up to 14 months.
Huh. Why would it work specifically for deep pain, but maybe not for general dryness or looseness?
Because dyspareunia is closely linked to the deeper vaginal wall biomechanics, the actual physical architecture and flexibility of the tissue.
Okay.
The deep thermal injury from the laser forces such intense collagen remodeling that it seems to genuinely alter the mechanical flexibility of the stroma. It reduces the pain caused by friction in a structural way that just treating surface dryness with a moisturizer doesn't achieve.
So what does this all mean for the patient sitting in the clinic right now trying to make a decision? We have to look at what happens when things go wrong and how doctors are actually supposed to be treating these patients today according to the consensus documents.
Yeah. While it's true that many women experience zero downtime and report life-changing reductions in dryness and urinary leakage, severe adverse events are a reality.
The marketing might make it look like a simple facial, but it is a medical procedure with serious risks.
Exactly.
Our sources detail a case study that is genuinely terrifying. Now, you might be thinking, why on earth would a doctor use an experimental laser on someone highly vulnerable? And that brings us to the tragedy of the standard of care.
This specific case involved a 65-year-old breast cancer survivor.
And because her cancer was hormone receptor positive, she absolutely could not take estrogen therapy for her severe vaginal dryness, right?
Correct. It could literally cause her cancer to return. So, facing severe discomfort, she opted for the laser.
Right. She underwent 3 sessions with a CO2 laser. A few weeks after her final session, she engaged in intercourse.
And the mechanical stress on that newly treated, essentially burned tissue resulted in a disastrous outcome.
It resulted in heavy traumatic bleeding. She had to be rushed to the operating room and put under anesthesia, where doctors found 2 severe lacerations deep in the vaginal wall.
Just horrifying.
But the nightmare didn't even end there. Months later, she returned to the hospital with severe, debilitating pelvic pain. Her vaginal canal had foreshortened to just 2.5 centimeters in length, and it was entirely filled with thick, fibrotic scar tissue.
It is a tragic case, and it perfectly illustrates the absolute worst-case scenario of the thermal scarring debate we discussed earlier.
Yeah.
The intense heat didn't rejuvenate the tissue, it traumatized it to the point of structural failure and permanent disfigurement.
Which is exactly why authoritative guidelines, like the UK's NICE guidance, emphasize a strict, stepwise approach to treatment. You do not walk into a clinic and start with a laser.
The first step must always be conservative, proven care. That means supervised pelvic floor rehabilitation with a specialized physiotherapist.
And it means using scheduled, high-quality, non-hormonal moisturizers.
Yes. And if the patient is a candidate and doesn't have contraindicated cancers, local vaginal estrogen applied directly to the tissue.
And only if all of those proven safe methods fail entirely should experimental energy devices even be considered. And the consensus says it should usually only be under strict clinical audit.
We also really have to draw a hard line between treating GSM and treating severe laxity here.
Right.
If a woman has severe laxity, meaning a major physical loss of vaginal pressure because she physically tore her levator ani muscle during childbirth, a surface laser is not going to fix that.
Because the laser only penetrates a few millimeters into the mucosa, it doesn't reach or repair the torn muscle hammock beneath it.
Exactly. A torn muscle requires surgical vaginoplasty to physically suture and pull the muscle tissue back together. Selling a surface laser treatment to a woman with a torn pelvic floor is missing the anatomical root cause entirely. It's a fundamental misapplication of the technology.
So it's not a magic wand. It is a medical procedure causing actual trauma to human tissue. It requires incredibly careful patient selection to ensure women aren't being sold lasers when they actually need pelvic physical therapy or surgery.
This raises an important question, though, bringing us back to that 65-year-old breast cancer survivor. Patients with a history of hormone-driven cancers are locked out of the standard of care.
Yeah, they can't use estrogen.
Right. They're often the most desperate for relief from GSM, which makes them highly vulnerable to aggressive marketing for these energy devices. They desperately need viable, non-hormonal options.
Which highlights the vital, urgent need for well-designed, randomized, sham-controlled trials. We need to know definitively if these devices are safe and effective and exactly how they work.
So that vulnerable populations have proven options rather than being treated as guinea pigs for repurposed aesthetic tech.
Exactly. So to distill all this down for you listening, non-surgical vaginal tightening basically relies on powerful energy devices, lasers, radio frequency, and ultrasound to cause controlled micro-injuries inside the body. The goal is to purposefully damage the tissue to trick your body into producing new collagen and blood vessels to heal the burn.
And while a significant number of women do report incredible life-changing short-term relief from pain and looseness, the broader medical community is practically shouting a warning.
Right.
We simply lack the long-term proof that this is safe, true tissue regeneration, rather than just temporary, potentially dangerous thermal scarring masquerading as a cure.
Which brings us to a final, provocative thought to leave you with today. Let's think back to the root cause of genitourinary syndrome of menopause. It is fundamentally driven by a systemic, body-wide lack of estrogen.
Right, the missing water from the sponge.
Exactly. If these energy devices simply inflict a local burn to trigger a temporary rush of collagen production, what happens to that brand new collagen when it is immediately subjected to the exact same estrogen-deprived environment over the next 5 to 10 years?
That is the million-dollar question.
Are these machines truly curing the environment, or are we just building a brand new house on sinking sand?
It's a foundational biological question that the clinical data simply hasn't answered yet.
And until the diagnostic landscape for women's pelvic health gets a little less murky and the clinical trials catch up to the marketing, that's a question you'll have to ponder. Thanks for taking this deep dive with us.